things done, like paying your bills. So on a neuropsych eval, they're not going to ask, do you pay your bills on time, for example. So we see here the prevalence also is really, I'm going to start off by talking about the prevalence, kind of the neurophysiology, neuroanatomy, neurobiology. So you all can get a really good idea, well, hopefully at least an idea of what we're talking about when we talk about ADHD. And then from there, I'll move on to diagnosis, treatment management, what to look for in your office, etc. But let's just start with a little bit of, what is ADHD? So first of all, it's very, very common. It's considered one of the most common neurodevelopmental disorders or condition of childhood and persisting into adulthood. So when I went to medical school a while ago, the thinking was kids just grew out of it. And so we had basically zero information about ADHDs that persist into adulthood. But now the studies over the past 20 years or so have found that a majority of kids who've been diagnosed with ADHD go on to have symptoms throughout adolescence and adulthood. So it's becoming more and more recognized and looked at. And we also, in children, it's also been noted that way more boys than girls, if they are diagnosed, get diagnosed. Now in adulthood, I only manage adults with ADHD. It's more like 50-50. And there are a lot of reasons for that. So not only are we picking this up more in adults, but also seeing that the female or the male-female ratio is very different than what we thought. So it's closer to 50-50. The largest demographic where we're going to see the increase in the diagnosis of ADHD, which I find really exciting, are in adults 50 and over. So more of that demographic is being looked at and trying to take more note of that. So it's important to realize that there's significant impairment in occupational, academic, and social functioning. We're going to see that. So the prevalence in adulthood, we're looking at approximately 5% of adults in the US. And if you look at studies, they'll say anywhere from 4 to 6% or so. Therefore, that translates into about 10 million adults. Fewer than 20% are diagnosed, and even way fewer are medicated. And then the question is, of those medicated, how many of those people are compliant and remain on their medication? And we know that medications are highly effective for helping with symptoms of ADHD, and the person's level of functioning definitely improves. Okay, so next slide. We also see that there's a higher prevalence of ADHD in other conditions like substance use disorder, anxiety, mood disorders, sleep disorder, eating disorders. So we're going to see in those patients an even higher prevalence of ADHD. So we have to start thinking, could there be an underlying situation with ADHD going on here? Often that is overlooked. So instead, the focus is on what the patient or client comes in. They're talking about anxiety or depression, and the focus is on that and not necessarily on what is leading to the increase in anxiety or the depression, et cetera. So we really need to view this with our eyes wide open and our minds wide open too. Okay, so also the comorbid, what we call comorbid or co-conditions with adults with ADHD tends to increase with age. And the more ADHD symptoms you have and the more severe they are, it's more likely that you're going to develop even multiple mental health conditions. So not just maybe a heightened level of anxiety, but also maybe depression and substance use disorder, antisocial personality disorder, etc. So the I just want to mention real quick, there was a meta-analysis of 29 studies of adults with substance use disorder, and the lifetime prevalence of ADHD was about 23%. So that's pretty high. Here is a picture of a very complicated highway system. And when I think about the circuitry, we're going to now talk a little bit about neuroanatomy and what's going on in the brain. So our brains are composed of about 86 billion neurons, brain cells, and each one of those, and then the brain cells kind of line up in circuits. And I have a representation there like of a complicated highway system. And that's what it's like. You just have all these circuits going from one part of the brain to another part, crisscrossing over, extremely complicated. And within the circuitry are the neurons. And like I said, there are about 86 billion neurons. And at any time, each neuron can communicate with 10,000 others. So that, therefore, at any given moment, trillions of connections are being made in our brains. So I have there, cars on the highway. That would be like the neurons, along the circuitry in the brain, and they communicate with each other via neurotransmitters. So the NIH began a study in 2009 looking to map the neural pathways so we can get an understanding of when a thought happens in the brain, where does it go, to which parts of the brain, and how does that influence our behavior. Okay, so the next slide. Here and here's just to talk about the various neurotransmitters or modulators: amphetamine, noradrenaline, dopamine, serotonin, glutamine, endorphins, GABA. So there are a number of neurotransmitters that the cells release to communicate with one another. So you need to have they have to be able to manufacture a certain amount of neurotransmitter and be able to release it, and the next neuron has to pick it up and carry the message to the next one down these circuits. So in order to, we want to have like the right circuits functioning at the right time with the right amount of neurotransmitters in order for, our thoughts and feelings to, for us to be able to self-regulate and function. We also have to be able, next slide, to be able to switch gears, so to speak. So we could be, if we're initiating a task, we're going to hop onto one circuit in the brain to be able to initiate that task, complete it. So all these neurons that are involved in that thinking connect together so we can, start a task and then follow through, complete it. And we prioritize the task. We're motivated to do that task. This is all interconnected and interrelated. So we have to be able to stay on task and not get off, a certain circuit, because that can lead to problems if that happens. The most notable deficits are in the area of attention in general as it relates to ADHD. And when we talk about brain, it's the prefrontal and subcortical areas of the brain that we're going to be talking about. Okay, so here we have a schematic of the prefrontal cortex, and we are looking at the main areas. That's the most highly evolved part of our brains, and that is where, I guess, the director of the orchestra sits, or the executive secretary. All this information is coming in from other parts of the brain, and then our prefrontal cortex sifts through it, and ultimately we, will be able to behave and operate in a way that will allow us to do what we want to do and succeed and etc. So we're talking primarily about the prefrontal cortex, but other areas of the brain are involved as well in the circuitry that has to do with attention and behavior. So we see here on functional MRIs and CT scans that there can be structural brain abnormalities among patients with ADHD. The most common are, like I said, the frontal cortex, the cerebellum, the subcortical structures, and I'm just going to throw some names out: the putamen, the globus pallidus, the caudate. Those are all parts of the cortex that is subcortical structures that aren't involved as well. But as one ages, those areas of brain seem to be less, they seem to mature, but it's the prefrontal cortex that continues to be dysregulated. So we know that focus is not just a matter of willpower or motivation, it's a function of the axonal fibers, that connection between different regions in the brain and the neurotransmitters to allow us to be able to prioritize, time manage, self-regulate, self-awareness, etc. So multiple areas of the brain involve multiple circuits, but the neurotransmitters primarily that we talk about are dopamine and norepinephrine as being lower levels than one would expect. So next slide. And here we just see some networks. We have the default network, for example. And on the other side, we have here the central executive network and the salient network in the middle there. And so, for example, if you're going to initiate if you need to initiate a task, then the cortical executive network would kick into gear. And if your thoughts start wandering, the default mode network will not be turned on. In ADHD, we see that it's turned on more than in a neurotypical brain. So the ADHD person can try to begin a task, but then suddenly start wandering. Mind starts wandering because it's going into the default mode network when it should stay on the other central executive network. So it's kind of flipping over to other networks, thus the thoughts, the wandering thoughts. Okay, the next slide. So here we see focus is a function of the axonal fibers connecting different regions of the brain. And this is really complex. So more and more work is being done to look at all those connections and what is going on that is making it so difficult to initiate the tasks that one is less interested in and sticking with it, completing it in a timely fashion, prioritizing, etc. And having that time awareness. So here we see two neurons, and there's what's called a synaptic cleft between the neurons, and then the neurotransmitters are excreted from one, the other one picks it up, and here we're seeing like lower levels of dopamine and noradrenaline or norepinephrine being excreted. So thus it's more challenging to get the messages through to the next neuron if you're also have lower levels of neurotransmitters around. So the circuitry could be off and the chemicals, the neurotransmitters could be lower. So I just want to mention epigenetics. So the risk of ADHD in parents and siblings of kids with ADHD in parents and adults would be increased 2 to 8 times. So the risk of ADHD in parents and siblings of kids with ADHD is increased 2 to 8 times. The heritability is at 76%. So if you take twins who are separated at birth and you look at, how they are later in life, that's one way of seeing, how heritable are these genes. So we know that in ADHD, we talked about the circuitry and the neurotransmitters. There are multiple genes involved in the issues that I just described. Not just one gene, but multiple. And it's very inherited. It's one of the most inherited of the neural networking that we have. And ADHD, one of the most inherited conditions, more so than depression, anxiety. So multiple genes are involved. Many have to do with the dopamine transporter and the receptor genes. And why I like to mention epigenetics, because it's not the biological traits that we're seeing, the changes cannot just be explained by the person's genetic code alone. So if you have identical twins, let's say they have a lot of genes for ADHD, one twin may do better than the other functionally. And why is that? Well, it's because there's, the environment is very important, and the influence of stress, adversity, trauma, environmental factors on genes, and even hormones can affect genes. So you can get a difference in gene expression by the exposure to environment, stress, etc. So lifestyle can have a significant impact. So it's not just about what you're genetically predisposed to, what you inherit, but also many other factors as well. So the next slide, and here are some clinical manifestations that we can see. There's an executive dysfunction. This is all relating to the prefrontal cortex. Executive dysfunction, deficits in working memory, task shifting, self-monitoring, initiation, etc., inattention, hard to remain focused, to organize, prioritize, follow through, impulsivity, excessive involvement in activities or tasks. And this is as it relates to the adult. Hyperactivity, there's fidgetiness, restlessness, overtalk, interrupt. So you can see here, and then emotional dysregulation is another huge area that's being talked more about and looked into. There's mood lability, the changing of moods pretty quickly, the irritability, the anger outbursts, low frustration, and motivational deficits. So this can be, these are pretty significant, areas to think about. And I'll give you an example of a patient. So a patient of mine who's an attorney, worked for a very prestigious law firm on the East Side, family, been married 20 years, kids, preteens, been working really super hard and seen him for a while. And then I saw him recently, and he had decided to quit his job. It had become just too stressful. And shortly thereafter, he got into an argument with his wife in front of his kids, and one kid called 911. So the cops came, and in the meantime, the my patient had gone to take the other kid to urgent care to look after a medical issue, came home, and the cops are there. And since he hadn't really done anything, except yelled and carried on, cops left. But then my patient became very upset that the cops were even called by his kid, that he became even more angry and in an outburst threw his wife's cell phone on the ground. And the wife called 911. The police came back and arrested him, threw him into prison. And he is now not able to see his kids, for something like a year. He's in probation because it was considered domestic violence because he threw her cell phone on the ground and caused property damage. So here's this guy who'd been doing pretty well, and suddenly his whole life changes because he had an anger outburst, and it led to basically losing his whole family, imploding right after he left his job. So let's go on to the next slide. The ADHD iceberg, I don't know if many of you have seen this, but what we notice on the surface here in ADHD is, we think, okay, fidgeting, trouble focusing, but there's really much more to it than just what we may think, oh, the person's just inattentive, fidgets, but there are so many potential outcomes that an adult with ADHD can have, which is not quite obvious, if you think about it. So you could see here, I don't know if you can read that, and if you can all, there we go. So trouble recalling, there's sleeping issues. It's very common in ADHD. Forgetting to eat, sleep, so time blindness, choice paralysis, very common. So all of these are very common symptoms. Just forgetful, very forgetful, working memory issues, can't remember what was just said, and difficulty maintaining relationships. This is a huge one. So there's a lot more under the sort of financial problems, anxiety, because you can't get anything done, and the mood swings. Okay, we can go on to the next one.
Okay, just like.
I know there was a question about addiction and ADHD. There's no direct genetic link between addictive behaviors and ADHD. Addictive disorders are very complex. They're caused by behavioral, emotional, life factors. But in ADHD, adult, there's like this thrill-seeking behavior, the need for immediate gratification. It's now or never. Search for novel, pleasure-seeking experiences. Way more common in people with ADHD. They get their boost of dopamine. So they're going to go out and seek some new hobby or new activity. And because of ADHD, there are a lot of life stressors potentially, like job loss, financial difficulties. So these are all risk factors for increase in substance use and abuse and other addictive behaviors. So they can resort to stimulants like cocaine or MDMA or caffeine, big time. They can, abuse alcohol, marijuana, opiates, sedatives, tranquilizers. There's like internet, as far as behavior, internet addiction, gambling, shopping, pornography, food addictions, which is both a physical and behavioral aspect of addiction. So it is way more common that you can understand now why an adult with ADHD might have more of a propensity towards using substances. Okay. So, and another question that came up was about the overlap, and this is very complicated because, is this ADHD or anxiety? Is this PTSD or ADHD? Is this bipolar disorder or ADHD? It could be all of, is this high functioning autism and ADHD? It goes on and on. So as a clinician, basically what I see is if you look at like anxiety or depression or bipolar or autism, and you just crank it down a notch or two, that could be ADHD, if that makes sense. So in ADHD, we can see, for example, if we look at, ADHD and PTSD, sure, in ADHD, you can have some depressive symptoms. You can have some poor planning skills. You can hyperfixate at times. There's some time blindness, but you're not going to have, unwanted memories or nightmares about a traumatic event, for example. So you can see they're in depression, hopelessness about the future. That can happen in ADHD, but usually it doesn't persevere as it does in depression. And you can have sensory issues, or impulse control, or working memory. Again, you can see that in PTSD. So basically, like, my general rule is, sure, you can see those, but how bad are those symptoms? And then I will investigate further. Is this also a case of anxiety as well as ADHD? So in ADHD, people do, they can persevere in their thinking and ruminate a lot, but in anxiety, it's more towards the negative, like, all the potential negative outcomes. Like, oh my God, my kid could get run over by the bus if they're waiting at the bus stop, and, somebody could kidnap them or what have you. That could be extreme anxiety, but in ADHD, there is anxiety that's mainly related to not getting things done and their procrastination, that they're still needing to pay their bills, etc. So not quite to that degree. They often don't, they don't have the nightmares associated with PTSD, for example. There could be some hyperarousal, but not to the extent that you could see in PTSD. So, okay, next, let's see here. So unmanaged ADHD affects all aspects of life across the board, because you can only imagine if your prefrontal cortex and executive functioning is off and your behavior can be dysregulated, how that can impact all facets of your life. So one, starting from a young age, kids will have more personal injuries and accidents, way more, and there could be undereducation. So it's very hard for them to get through college or even high school. Maybe college can be a struggle for many, and many who may have gone on to graduate work just find it impossible. So they may stop at undergrad. Unemployment, more so in adults with ADHD, underemployment, and they tend to have multiple jobs. That's another good question. How many jobs have you had over the past, 10 years or so? Do you feel like you're underemployed? Did you have desire to go on to higher education? Did you find, and what happened? There are increase in legal transgressions, parking, motor vehicle transgressions, incarceration. Divorce rate is much higher in adults with ADHD. They also tend to, they can have relationship difficulties. Like I was giving one case with my patient, that's often, there's a struggle there. Increased incidence of chronic health conditions, and their severity, like diabetes, hypertension, obesity. So, it takes work to try to manage diabetes or hypertension, or to get your weight down. You have to really think it through and organize yourself, plan things out, and those are all a challenge for an adult with ADHD. Thus, their diabetes can be much worse, or their hypertension. That leads then to very chronic and serious health conditions, which could lead to an earlier death. And therefore, the studies have shown that adults with ADHD tend to have a lifespan of 10 to 15 years less than people without ADHD overall. So that's, if you look at, the results of that, they're huge to the economy in general too. The billions of dollars that are lost because these adults are not functioning as well as they could. So, as a therapist, what are you going to keep? And this is difficult. How are you going to? Because patients, your clients probably don't come in saying, yeah, I have adult ADHD, and because of that, now I'm suffering from depression, anxiety, insomnia, and eating disorders. So how can you help me? I don't think it's going to be like that. So how do you kind of get into their heads and see, what, besides home of origin, what else might be going on that is, neurodevelopmental, based on neurodevelopmental conditions. So it is challenging. And I have a number of patients who go see therapists and report back and say, I didn't get anything out of it, or I didn't feel like they understood what I was saying, or what have you. So just next slide is a schematic from an artist who has ADHD, or let's see, which slide are we on next?
Is it next one? Is this the correct one, or next one?
You want to go to the next one? Yeah.
Sure.
Okay. Could my client have ADHD? What are some of the first things that you might want to note? And I would say first is just the client coming and presenting him or herself. So these are like basic things, like do they tend to miss appointments, or are they late for appointments? Do they seem distracted when they talk to you? Do they talk too much? Do they interrupt, go off topic, have tangential thinking? They're thinking one thought, then they go on to another one. That seems unrelated to, the question that might have been asked. Do they fidget, squirm, seem restless? This is what you're going to see in an adult versus a kid, more of that fidgetiness, squirming, restlessness. And they may find it difficult to, just keep their gaze looking at you. They might be looking around the office. Maybe they'll leave personal items behind. So I don't know, like hair clip, pens or what have you. Do they forget, or do they delay in paying their bills? So these could be clues that related to executive functioning and self-regulation that you might be able to, be aware of initially. When I started doing ADHD work, one of my first patients was a psychoanalyst who had written books, and she was in her 60s. And I was kind of nervous because I was just starting off working with adults with ADHD. But it was so clear cut when she walked in my door. And again, I was just beginning my work. I noticed immediately that the likelihood of her having ADHD was huge because of how she moved. She was fidgety, looking around my office a lot, but she was highly successful. So, don't let that be a deterrent, because I do see very highly functioning adults with ADHD. I don't work within a prison system. I work with people who are, very successful, yet, they can present in other ways. So I would say first, check it out and see, how are they looking at you? How are they sitting? How are they with their bodies? And how are they tracking the conversation? The next slide is a example of and I just had a patient today. It was really funny. He's in college, and he's a fourth year business major, and he was saying to me that he had been off meds for a while. And I said, well, why do you want to resume meds? And he's like, oh my God, I'm just like all over the place. I can't tell a story from the beginning to the end without apologizing. Okay. And I showed him the schematic, and he laughed, because as you see here, this is Danny Donovan is the artist with ADHD, and she does these cartoons and schematics are really, she nails it. But, so a neurotypical patient might come in, and there's the start of a story, and there's the end of the story. It kind of goes from A to Z. An ADHD client may come in, and there's like the pre-story, the prologue, the start of the story. What was I talking about? Wait, okay, back to the main story, too many details. Something I just remembered. And it just can go off in all kinds of directions. And then maybe realizing they were talking too much about that, they kind of want to try to wrap the story up, end of story, and then now they're apologizing because they talk too much and didn't stay on track. So this is kind of sums it up. Next slide. So what to do practically, having follow-up appointments made before the client perhaps leaves, so they're already set up, having text reminders of I have my patients receive text reminders, a couple of them, beginning several days before their appointment, and they can cancel or reschedule at that time. You can redirect the conversation as needed. Let's get back to talking about, remind the client how much time is remaining. We've got, 5 more minutes to wrap this up. Is there anything else you'd like to say? Having analog clocks around that are very colorful, exciting to look at, so the client notice the time. Minimal distractions in the office is very helpful. So not having a cluttered, chaotic looking office, more one where, they're better able to focus. And then keeping the client credit card on file, or you collect payment at time of the visit. So there's no accounts receivable and paying, sending bills and things like that they may likely not open, or open, months from when the bill was sent or that we received. So these are like some practical things that could be important in having an encounter with an adult with ADHD being more successful, more profitable. Next slide. So what next? You could consider a discussion about ADHD with a client. There are surveys. There's the Adult ADHD self-report scale. I don't know how many of you do give client surveys, but that could be one thing that you could have available if you're suspecting ADHD. And I know it could be a sensitive topic because there is unfortunately still a lot of stigma. Providing resources to your client. You could consider a neuropsychological test as only a tool, but I've seen a number of neuropsychological tests that have been inaccurate, in my opinion, after I've interviewed the patient at length. So a neuropsych test is just a moment in time or a day in time, but it's really like their whole life. Like when I showed the video at the beginning, what is life really like for these people? So when they do a neuropsych test, they're sitting in an office, it's quiet, no distractions. It's a very different setting than being at home with a couple of kids and a spouse. You just came home from work and you haven't gone shopping and everyone's waiting for dinner, that kind of thing. Kids need to go places. It's a very different scene. So, and then lastly, you might consider referring to a psychiatrist or a specialist, depending on how open your client would be to investigating further whether this could be ADHD or not. Because I'm saying all this because medications are extremely helpful. It is one area in psychiatry where medications are definitely very helpful, and the response rate is very high. There's about a 70-80% response rate to the medications. What these meds do is increase the dopamine and the norepinephrine levels within the brain. So it makes it, so it's less effortful for the adult with ADHD to have to, initiate a task, follow through, plan, execute, especially tasks that are boring and uninteresting but have to be done. Highly effective. So I wouldn't be doing this work if I didn't believe it. But I have so many patients. My work is very gratifying because I can see immediate results. These medications don't require time to kick in. You don't have to take it you don't have to take these meds every day. You can take as needed. I really empower my patients. I give them choices when they can take their med, when they don't want to take their med, and choices of long acting, short acting, and we review all of this. And they can really be very effective and improve quality of life in all domains for adults with ADHD. So it's really important, to let your patient know that there's definitely medication that can be quite helpful. Next slide. So it's important in the diagnosis of adult for a medical practitioner to often, sending a patient to a PCP with little knowledge of adult ADHD may not be the best way to go. Really, the more experience a practitioner has working with adults with ADHD, the better. So you might want to look into, is this something this practitioner does routinely or just sporadically? But the more that the provider works with these patients, the better they can gauge the situation, because there are so many symptoms and so many variations on the theme that it can be very complex and difficult, and you have to exclude other conditions before then you move on to giving a diagnosis and prescribing medications. Because, for example, if somebody has like bipolar disorder, you don't want to give them a stimulant that could throw them into a manic phase, for example. So you have to be careful with that. You want a practitioner who really understands the functional, psychosocial, economic outcomes of untreated or poorly treated ADHD. Like what are, if this is not addressed, and how important it is to address it and provide the right support. And also, a practitioner has a multimodal integrative approach. So it's not just about medications. I tell my patients that medications are like icing on the cake, but the cake, the multi-layered cake, I'm thinking of maybe a wedding cake, has to be really good. So the cake itself has to be, all the layers have to be great. And the med is kind of like the icing on the cake. Like this is going to really taste great, especially if the icing's good. So you want to make sure that it's not just about, and you can stress this with your client, it's not just because you just want to push drugs on them, but that, somebody who could, have a multifaceted, multidimensional approach can really help. So they could talk to them about other ways to help and intervene. Next slide. There was a question about gender and race disparity in diagnosis. We know, so there was a study done by the National Ambulatory Medical Care Survey, 2008-9, and then 12-13. They saw a 36% increase in adults being diagnosed with ADHD and 18% in youth. So that's quite high, and that was, 10 years ago. It's even higher now. 77% less likely the diagnosis among Blacks than whites. And then there was a multi-site study done out of University of Arizona, College of Medicine, looked at over 4,000 children and parents that were surveyed in waves, 5th, 7th, and 10th grade. And they saw across the board that African American, Latino kids were far less diagnosed and far less treated and managed than Caucasian white children. So there is a huge disparity. And then in adults, unfortunately, you do have to have pretty good health insurance. So you have to be insured. And if you're unemployed or underemployed, you may not have the greatest health insurance and be reluctant to go to get evaluated for ADHD. That won't be a priority. And then the medications are also can be costly. So it is more unlikely that those populations would even seek a diagnosis, let alone treatment. So it's a huge problem. And, I don't know if there are studies in countries with socialized medicine looking at whether that disparity is lower. But unfortunately, that's the case. So next slide. So when I talk about multimodal management, first, it has to begin with education and awareness. So, you want to be working with a practitioner who really has good knowledge about what we're talking about here, adult ADHD, and empowering the patient with knowledge and helping the patient develop more self-awareness around it. Because, it's one thing to be told you have adult ADHD, but it's another to really understand what are we talking about, what the complexity of what we're talking about and the manifestations. So as I said, medications are extremely important. Sleep becomes all the more important in an adult with ADHD because poor sleep really has an adverse effect on executive function and the rest of the brain, as we know. So, and there are often sleep issues in adults with ADHD. It's very common to hear about insomnia and sleep disruption. Their minds can tend to really kick into gear at night, unfortunately, and it's quiet and they are with their thoughts, or they can get really distracted by their cell phones and be on the phone until 2 o'clock in the morning. So they have a lot of sleep issues. There's regular fitness is really important because we know that with fitness, there is a release of neurotransmitters in the brain that happens pretty quickly. So the more intense the exercise and the longer the duration, the more neurotransmitters, especially dopamine, norepinephrine, the endorphins, as well as serotonin, are released. So the effects from that will last longer if the fitness is more intense and of longer duration. Mm-hmm. So that's an endogenous way of increasing the good neurotransmitters is through fitness and exercise. So again, something I discuss all this with all of my patients. Limiting caffeine, it's amazing how many patients I get from other practitioners and they've never been asked, like, how much caffeine do you drink per day? There's a lot of self-medication going on with adults with ADHD, and one of them is caffeine because it's legal stimulant. So there's, it's important to ask them about alcohol consumption and, marijuana use. So really, discussing substances with them. And then, of course, we know that CBT can be quite helpful in conjunction with medication, and actually the American Academy of Pediatrics, that is their recommendation, that kids be not just managed through medications alone, but also with therapy, CBT. There have been multiple studies showing the efficacy of that, both therapy and medications. DBT, dialectical behavioral therapy, especially important in that self-regulation of emotions, because there's a lot of dysregulation of emotions as well. Unfortunately, that's not a criteria for the DSM-5, the Diagnostic Psychiatric Manual for adult ADHD, and specialists in the field would like to see that as a diagnostic criteria because it is so important and pervasive, that emotional dysregulation. So DBT can be helpful. Coaching, very practical, helpful, and having that accountability, the coach. Mindfulness training, paying attention to what are you doing in the moment, trying to focus your attention in the present moment, and trying to sidestep the distracting thoughts that you might have. Neurofeedback, another modality that has been shown to have some efficacy with helping with the focus and attention. See that. So here are some resources. CHAD is the national organization. It has local chapters, including here in Seattle. One was recently started, and also on the east side, I believe. It was established in 1980s, Chad. They have national conferences, which I recommend for therapists, coaches, lay people, parents. So they usually have several days of talks that one can attend. Attitude, it's online digital magazine and resource, extremely helpful. They have short articles, up to date, written by experts, and they have a search bar and you can put basically anything in there, and it's really incredible. They also have a podcast, ADHD Experts podcast it's called. And again, they bring in and interview experts in the field on a number of topics related, of course, all to ADHD. There's a book that came out last year called ADHD 2.0 by Doctors Hallowell and Rady. They're out of Harvard. They are like the grandfathers, basically, in the field of adult ADHD, have been doing work in the area for about 30 years or so. And this is a compilation of their work, and that they jointly published this book last year, and it's obviously very readable, very up to date, a great resource. There is a coaching and accountability website called ADHD Rewired, because coaching can be expensive. This can afford patients a more economical way to go about. There's also a community that you can join through ADHD Rewired. And then unpackingADHD.com, it's Don Baker is a therapist out of West Seattle. He's been doing work in this area for 30, 40 years, and he does great group sessions with clients. So it's affordable. They're all on Zoom, and they are about, he goes for about 4 sessions and a lot of instruction. They're not like support groups, more instructional. And he talks about various topics and gives a lot of resources. So that's another great way to go for more information and support.
That's awesome.
And I think that's it.
Mm-hmm. Yeah. And can I share this presentation for everyone
Sure.
with the resources?
Sure.
I'll send this to you so you can have those resources
Sure.
In your inbox. But awesome. Well, wow. I mean, gosh, there's so much. Can we open up the floor for some questions, or do you?
Absolutely.
Is that kind of okay?
Absolutely. I know this was a lot. Maybe a bit too much, but
No, it's incredible. Oh, there's so many ways we could go. And I know that, probably if everyone, I'll speak for myself, but, pinging with people that come to mind, noticing my own fidgeting sitting here, just this awareness of thinking through, behaviors, but, and thinking through patients, that maybe you have questions about. So I'll just open the floor. I'm going to use the restroom. I'll be back, but go ahead and just ping your questions.
I have a question. What do you know and see about sensory processing disorder with adults with ADHD?
Yeah. So again, one of my questions that sometimes I'll ask patients as part of my survey is very simple. I go, where do you guys like to go grocery shopping? Now, if they go, I like to go to Trader Joe's. I'm like, bingo. Or if they don't mind going to Fred Meyer or QFC, Trader Joe's, like, for grocery shopping is pretty tame, right? Like, not many aisles. You don't have too many lights lighting up. You're not going down these long aisles. You don't have like a million options either. So they kind of decided, which ketchup they're going to sell, or, there's like one kind of mayonnaise or what have you. So the sensory overload is not as bad as if you had to walk into, I don't know, Fred Meyer and do grocery shopping. So what I'm saying here is that I do notice in a lot of patients adult patients with ADHD, there is sensitivity to sounds, to, different choices put in front of them. Like if I have to look at 10 mayonnaises or 10 ketchups, like, oh my God, well, it could be that one, or it could be that one. Maybe it could be that one. That's overwhelm. So I guess visual, auditory, not so much textile. Like in autism, you're going to see those kids being very sensitive to maybe their clothes, for example, like what they wear. You don't hear that as much. I don't hear that very often, if at all, in ADHD. So again, it's kind of like that, but kicked down a couple notches, if that makes sense.
Do you have a lot of patients with adult patients with ADHD who also have SPD?
So I knew you were going to ask that. The answer is I don't know, because that is beginning to be more looked at, and it's not readily diagnosed. There aren't many practitioners out there that they could go to and say, yes, you do have, ASD, you're on the spectrum. That's not something that I specifically do. So it is something that I have to be very aware of, but it's not being diagnosed like it should be. I think we're just beginning to talk about it and seeing in the last couple of years, looking at the interactions, the overlapping symptoms between autistic-like, symptoms and ADHD. So there are genes that you're going to get, the expression of ADHD and autistic-like symptoms that overlap, if that makes sense.
Are you saying that SPD? Are you referring to SPD as autistic-like? Is that what you mean?
Well, on the spectrum.
Yeah. I have a client who I'm wondering if she has SPD, and she's also told me that she has ADHD, and we're
Okay.
kind of. She definitely does not have autism, but she said, I wonder if I have autism. And so that's sort of where I'm going with her, is she's got also some features of body dysmorphia and just having a really unpleasant experience in her body. So that's why I'm kind of trying to understand a little bit more about SPD and what you see.
So what I do see is, yes, I do see characteristics of that in my ADHD patients. Can I officially diagnose it? Do I? No. Have they been officially diagnosed? Not necessarily. I think it's hard to find someone who would, definitely be able to diagnose that. What I do is I work with their symptoms, and I say, okay, if you're going to feel overwhelmed going in that place, then maybe go to this place, for example. But you see also the social aspects of that, because in ADHD there is social awkwardness, but not quite like you see in the spectrum, right? So they do have relationship difficulties, but and sometimes they can find it difficult to read what other people are perceiving about their behavior. That's pretty typical in adult ADHD, but not to the extent that you might see people on the spectrum.
Yeah, I don't think she has a lot of relational difficulty. I think it's mostly the sensory stuff for her. So that's what it's about it.
Okay. Yeah, so to answer your question, yes, but I don't see like the textile sensory as much.
Oh, you don't? Okay. Interesting. Yeah, she reports that as being one of the most distressing.
And it could be, I'm not soliciting that. I don't ask those questions. Maybe I should.
Yeah.
It could be, but.
Yeah. Okay.
But there's definitely an overlap between, and my thought is that at some point ADHD might be considered to, be part of the spectrum.
Yeah.
I would not be surprised.
Thank you.
You're welcome.
I have a couple questions.
also thank you for doing the training.
Oh, you're welcome. You're very welcome. Thanks for having me.
I don't know. I like my first question is like kind of messy because I'm thinking about like my little sister who like uses TikTok a lot, and how like with that population, like she has told me like a lot of her friends like have ADHD, right? And I'm even getting this with mostly my younger clients, but like I have some clients right now who are like 18, 19, and they're like I really identify with this and this experience. And then also, like, I just watching that video, it was like watching a video of me like any day. And I also like have sensory issues. Like you said, Trader Joe's was chill, and I was just like, I would like rather like get hit by a car than go to Trader Joe's. And like I moved here recently from the Midwest, and I absolutely had a panic attack the first and only time that I went to Fred Meyer. So it's just like I like notice these things even with myself. And I guess my question is kind of like, have you noticed in the work that you do, or kind of the research you've done, like is there like a reality that we're kind of living in a world where attention spans are like a lot shorter, and that's almost like mandatory, because to be on top of things, it's like stuff is just so quick all the time. And then I'm also thinking like one of the biggest things that's made me think like I've never considered getting tested for ADHD, even though like I genuinely resonate with like a lot of this. Like I'm like, wow, okay, maybe I do have ADHD. But the friends that I know who have ADHD, who are medicated, the difference like between when they are medicated or when they like are behind or can't get their meds, it's like it like debilitates some of the people that I know. And so I guess I also have this question of like, if someone is concerned that they might have ADHD and they were to get on medication and the medication was not providing like results, would that be a pretty clear indication that ADHD is not something the person is dealing with?
Okay, let me start with that question first. I'm going to work backwards. That's a loaded question. So medications are complicated. Because it's not like if you come to see me and you have a bladder infection, right? I have an algorithm. I'm like, 30-year-old white female doesn't have any other chronic issues. Give her this for 3 days. Take whatever, fluoxetine for 3 days, and it should be resolved. And then we'll know. There are about 34, 35 different formulations of ADHD drugs approved by the FDA to use to help with ADHD symptoms. So we're talking about 35 different choices. And these choices aren't I don't choose, I just don't automatically go to one of those 35 choices, because it's not based on age or weight, gender, anything like that. And I also have to consider the number of symptoms and the severity of symptoms. So you just saw there how many things I'm thinking about before I prescribe. Mm-hmm. So you can go to one practitioner who will just go, okay, Adderall 10, or Adderall, I'll give you Adderall, I don't know, 20, 30 milligrams, and out the door you go. Or you can get practitioners who really understand the medications and the different choices. And so your experience with the med will be really dependent upon what you're given, how much you're given, and the education you have around the med. I don't know if that's helpful or not. So it could be that I just inherited a bunch of patients coming from 2 other ADHD practitioners. So one died and the other retired. And I'm getting all these people like on 90, 120 milligrams of amphetamine a day. Hmm. Now, I never prescribed that. I don't think I've ever prescribed that in my patients, that amount of amphetamine. So it's really practitioner dependent, like who you go see as to who, it's kind of like dialing in a radio station. Like, it's like turning the knob. Like I've got to turn that knob pretty quickly, and so I can get a clear signal. I don't want to be futzing around with that knob. And if the longer it takes me to zero in, that's going to be discouraging to the patient. Because if I just say, oh, go take this, bye, see ya, and for whatever reason it doesn't work out, they will probably just give it up and go, why should I even be medicated? Meds suck. I mean, I'm just getting like numbed out or whatever. And so I'm going to lose a potential ADHD, turn somebody off to meds who has ADHD, who should be medicated. So I have to be very careful because I don't want to have them, turn around and be discouraged and never go see any other practitioner because they had a bad experience. Mm-hmm. If that makes sense. So your next question will be, well, what is it based on? Like what? So here's my second survey question. My second survey question is, are you a cheap date? Okay, so does it take you, if we go out for cocktails, is it going to take one cocktail or one beer or one wine for you to feel like tipsy or loopy, or will it take, 3 or 4? And if they tell me, oh God, no, I just like deal with one and that's it and I'm good, I'm automatically thinking, okay, this person could be a slow metabolizer of these drugs, because the enzymes used to metabolize these drugs are similar to what would be used to metabolize like alcohol, narcotics, for example. So I have to gauge pretty quickly, like how fast of a metabolizer of meds, not of food, because people go, well, I can eat, a lot. No, it's of meds, so that I can gauge the dosage. And so if I think that if they tell me like, oh, I can only do like 1 beer, I'm going to start very low and I'm going to have them titrate up. I'm not going to give them 20 or 30 and pound them over the head. Mm-hmm. I'm going to start very low. Mm-hmm. Or if, I have one patient who's this Mormon mom, not that I have anything against Mormons or that they're all conservative or whatever. No, but, regular mom, East Side kids, she does not look like a drug dealer. Is what I'm trying to say. She's on my max. She's one of the people that I have on max that I prescribe of amphetamine, and it's working okay. I'm not going higher, but she like needs a good 60 to 90 milligrams a day to have an effect. So it really I have to really understand, and people can throw me off. I can get a very thin patient who has, very symptomatic, maybe is a physician in training who's very thin, who is going to require more med than another person, or an obese patient who microdoses. I have that too. Now, your other question, I think, was about, do you have, how do you know that you don't have ADHD, right? Or in our society.
That, but like, do you, like in your expert, experience, like, does it seem like there may be pretty big increases in the number of folks who are diagnosed with something like ADHD or potentially have it and are undiagnosed? Or does that seem like that's something that just looks that way in like my bubble of understanding 18 and 19-year-olds who like frequently tell me that they think they have ADHD?
Well, number one, it's the field of adult ADHD, like I said, has just been, even since the time that I trained, even acknowledged. Okay, so we started acknowledging it and saying, okay, not all kids grow out of ADHD by the time they hit, 18. That's been relatively recent, like the last 20, 30 years. So we started to acknowledge that, okay? And there's been more of an acceptance that no, as a matter of fact, most people go on to displaying symptoms of ADHD. So there's more awareness around it, more education around it, more research being done about it. And so it's being diagnosed better and more, I would say, in general. So that's one reason. I'm not going to blame it all on TikTok, or Snapchat, or cell phones, but we're getting better at being able to understand the complexity of what we're talking about and how it can persist and change over time. So you're not going to get an adult jumping off of tables and running around rooms. Okay, the adult will be in your office fidgeting. Okay, I just went to lunch last week with a PhD psychologist colleague of mine, and for lunch, and I swear the whole time she was like distracted looking at other people, other tables. It was really disconcerting. And she has ADHD, probably unmedicated, but it will just manifest. So the symptoms that we have acknowledged can occur in childhood and early adolescence, can change over time through adulthood. So you have to just be aware of that. Now, social media, having cell phones, is making it much, much, much more difficult to somebody with ADHD to self-regulate, right? Because that's already an issue. Their dopamine is low. They're wanting the hits, and they're seeking them out there. And then now you have a cell phone in front of them, right? And the cell phone is just, they can go down all kinds of rabbit holes on the cell phone. So it's really hard, that kind of addictive behavior, having the availability of a cell phone right in front of, or, a TV or whatever, a laptop, is going to make it just way more challenging. So one thing I show patients, this is a self-constraint, this is called the kitchen safe. I don't know if anybody has seen this, but sometimes you have to resort to something as drastic as this. So you could put whatever in here, like a cell phone. I drilled a hole. My son has ADHD, so I drilled a hole so he could put his cell phone in here and charge it. And then you could set the time, and then it opens like after 4 hours, or sometimes you really need that. And I tell my adult patients, go get a kitchen safe. Comes in different sizes if you have to.
Yeah.
My ADHD son, who was 16 at the time, said, "Let me turn the dial. Let me turn." And so he put 3 days instead of 3 hours. So he didn't have this for 3 days. And then I saw him going down to the basement with this in hand because he wanted to take a hammer and so it could resort to things like the kitchen safe. And I say, if it amounts to that, go for it, because just moving a TV screen from a bedroom or a living room over to a family room, over to a different, out of sight, for many people with ADHD, out of sight, out of mind. So just physically removing that, but that's a huge problem, huge challenge.
Mm-hmm. Thank you.
Yeah, you're welcome.
I have a question about adults who have been masking ADHD symptoms for a long time. I'm a big fan of the therapist Casey Davis, who talks about her experience of getting diagnosed and how she was able to compensate and not interrupt people, because she chatters her teeth, but no one notices. So I guess I'm just wondering, I don't know, that kind of threw a wrench in things for me, hearing about it can really be masked and people can compensate. I guess I'm wondering your thoughts on that, or what we should look out for. Yeah,
a good question. So my first question is do they know they have ADHD and just are embarrassed, shamed to say that they have ADHD, or do they not know they have it and they don't know that they're masking these symptoms? I would say that would be one question I'd have. But there's still a lot of shaming around the diagnosis. First of all, I don't like the the label of ADHD because it's not that, right? People with ADHD, I mean, all my patients are highly successful, highly educated, and and doctors, lawyers, and software engineers. So they can clearly pay attention, or they wouldn't have gotten through school. And they're not necessarily hyperactive. Mm-hmm. So there's got to be a new name for this. One name that's been thrown out there is VAST, variable attention stimulus trait. I don't know if anybody has heard of that, but variable attention stimulus trait sounds less negative. And that just means depending on the stimulus and how interested you are is how much attention you are going to pay, right? Variable attention stimulus trait. Depending upon the stimulus, you will pay more or less attention. That's a big part of ADHD. Again, that's not the only part, not the only major thing, because we talked about emotional dysregulation, for example. But, so a lot of people, like, who wants to, even a kid, like, who wants to be told they have a deficit and a disorder? Yeah. So you kind of grow up with that notion. Yeah. I mean, that's pretty negative. Used to be called moral deficit disorder in the 1900s. Another nice name for it was minimal brain dysfunction. Another name was hyperkinetic syndrome. So ADHD might be a little better than moral deficit disorder, but we're not there yet. We need to have a better name for this. So that's one thing I would say, in beginning to answer your question. So the masking or covering up. So if people have ADHD and let's say they have genes for anxiety, so they have more anxiety than what is helpful to have, because we all have anxiety, we need anxiety. Their anxiety may push them to overcompensate for weaknesses that they know they have, but they may not know why, if that makes sense. So if they know, for example, they're time blind, like they've been late and they might have had one, bad consequence, like somebody told them off because they were late. Now they also have anxiety. Well, their anxiety may overcompensate for the fact that they could easily be late. Right. So they're going to like show up early all the time because they are going to, damn it, they don't want to ever do that again. Yeah. That would be one example. So those people are very hard to diagnose. And I actually had a patient who, oh God, I forget if it was a time issue, but she didn't want, so she was working remotely, but sometimes she had to go into work. And working remotely, she would start at 8 a.m. But sometimes when she took the bus, she would arrive at work like at 8:30 or 8:45, and she was so upset with herself. And I said, but your work is flexible. Like, does anybody in the office care that you're there at 8:45 than 8? And she's like, no, not really. And I was really trying to understand, why was it so important for her? Why was she feeling so bad about not being able to change her routine on the days that she went into work so that she could be to work at 8, which would involve changing routine. It was so hard for her to change that routine. So she was so shameful and humiliated. Well, it turns out that when she, digging a little bit further, I'm not a therapist, but when she was growing up, it was instilled upon her that they had to be on time. So her parents, like, that was, it was just drilled into her that being on time was really important and essential. So in that case, she could probably benefit from cognitive behavioral therapy. Like, is it really important now that look what's going on here. Look how much stress that's giving you. Is it really, where is this coming from? So I hope I answered your question, but
Yeah, absolutely.
Yeah,
If
so
I
you
could ask one more, even can like any ADHD symptom be masked, or are some like too pervasive or affect functioning too much to be masked?
That's a really good question. It would depend on how motivated, like again, do they have other disorders going on, like anxiety disorder? And then also how motivation's a big one too. Like if you're really motivated to graduate college, you will, for whatever reason, again, motivation is from another areas from our parietal lobe, not prefrontal. Then you will do whatever it takes to graduate. So, and again, I see very successful people. So how did they get there? Well, a lot of it is, they're very, very motivated, and what leads to having more motivation than less motivation. Those are other areas in the brain that connect with the prefrontal cortex so that you get shit done that you need to in order to do what you are motivated to do. So to answer your question, yes, it can be very difficult. And my job basically is to it's hard because I have to kind of look through all of that because I'm seeing in front of me a physician or an attorney or an engineer. And I have to really say, okay, I don't look at their accomplishments. I'm looking to understand how difficult it, just like that lady in the video, it is for you to go from A to Z. Let me try to get into your head and explore how much effort does it take for you to go from A to Z? And they're like, oh, I stay after work a lot, or I had to stay in the library a lot. And I go, oh, well, compared to others, was that a lot more? And they're like, yes. So they're not ever being asked these questions. And that's why on a neuropsych test, you may not get, you're not asking the right question to get the right kind of information, right? So I have to ascertain more, the effort involved in doing things, including being self-regulated. And if they tell me, boy, it's been so hard, let me tell you, then I'm like, oh, tell me, just how hard is it? So a neurotypical person, they can engage in a task that is not really interesting. Like if you hate history but you have to read, 3 chapters for the next class, you're not fighting it. You have to do it. So you're going to initiate the reading of your 3 chapters and you're going to stay with it until you finish. Because that's a priority because you have to go to class, I don't know, in 2 days or not, maybe 3 days, and you need to have that read. And you just have to do it. You're not thinking twice or 3 times or 10 times about it. So if you look at the effort involved in that versus somebody who's like, I don't want to start reading this. I hate history, but I have to take it. I hate it. Oh, and then they see something, a squirrel over there. All right, well, I'm going to go over there. I'll get back to that. And they never do. Right? Or they'll tomorrow, again, time blindness, right? Not prioritizing, not realizing how much time it's going to take to read those 3 chapters. How much time do you have left? Their minds are going any which way. So you see how much effort so then it's like midnight the night before class and they're going, oh yeah, I was supposed to read those chapters. Maybe they won't do it because now they're on TikTok all night. So they might not do as well the next day. And so they're sleep deprived because they were on TikTok and they didn't do the reading of the 3 chapters. So now they feel like total shit and their grades get worse and then they can't, it just, you see where I'm going with this.
Yeah, I love that question, Erin, because I had a similar, this is really helpful because there was someone who had really presented not a lot of symptoms, but was experiencing exhaustion every day by around 3 or 4. And it was severe exhaustion. And was looking into, a lot of underlying medical conditions and wasn't finding anything. And when they were diagnosed with very severe ADHD, it was interesting because I also had, it was hard. The masking was so, highly successful, but just experiencing exhaustion and realizing how much work was going into staying on task up until 3:00.
Right. And let me say, it's not necessarily masking on a conscious level, right? Like they don't know they're masking.
Right.
It's just, and in the clip that I showed you at the end, the lady says, and this is why I like the clip. She's like, I'm so tired and yet I got nothing done. Yeah. Right. Because there's a physical fatigue as well as mental, which people do not understand. So these people will come home, let's say they're married, they have a partner at home and stuff, and they're like, I'm exhausted because they had to keep everything tightened, buckled up at work, and it's exhausting. It's exhausting to go to work, especially when you have a work environment where everybody's on the same floor, open work environment, a lot of chaos and a lot of stuff going on. It's exhausting to have to constantly put the brakes on. So there's a physical exhaustion, absolutely. And again, going back to that video clip, that's what she says. I don't know why I feel so tired. And it seems like I got nothing done. That's exactly what it feels like.
I think you mentioned the impact of environment and trauma and those kinds of things. And what's coming to mind for me as you're talking about this piece now is the significance of like relational stories about the symptoms that we may now understand are ADHD. I mean, I read a lot too about ADHD in women looking very different, and for so long being thought of as like, oh, girls don't have that. And all of the stories that for like girls and women where ADHD symptoms show up and they're being called irresponsible, or they're being called lazy, or they're being called, things like that, where I would not be surprised if people are very, very, very hesitant about admitting that that label has landed on them, even to, a provider, until it feels like there's some sort of safe rationale for what that could be that isn't just like a character flaw. That stands out to me a lot as like an ingredient.
Yeah, I mean, we could have a whole session on girls, boys, women, and men. Because it can be very misleading in girls. Yeah. I have a very good friend of mine who's has an MBA, worked at Boeing, and really good about his mental health. So had seen a number of therapists over 20 years, like 10 different. And sometimes he'd mention to the therapist, do you think this could be ADHD? And they're like, no, there's no way you could have it. You're just, I mean, look at you, have family, kids, you're successful, you're at Boeing, climbing up the ladder. And, years later, I don't like to diagnose my friends or family, but at a certain point I said something. He went back to his therapist, who said, okay, well, I guess I'll send you to the neuropsychologist. And he went, and I read the report, and even though he scored high on the ADHD questionnaires and surveys, and the psychotherapist didn't say that he has ADHD. It wasn't mentioned. And so anyway, I encouraged him to go see somebody who knows more about ADHD, which he did, and now he's medicated. And they're like, and then his therapist is like, oh yeah. So, so girls, women, that's why I'm seeing about 50, in my practice, I have about 50-50 women and men, because that's probably more, what it's like in childhood and adolescence is just the girls are not being picked up. They're the ones that kind of sit in the back of the room, they look out the window, they are, called aloof maybe. They're not very necessarily hyperactive. And so they just don't get picked up. And it's usually in adulthood, and typically after they have a kid who may receive a diagnosis because it's very inherited, and then go, oh, I wonder if, I acted like my kid when I was growing up. I wonder if I have ADHD. But girls, we as women there's more of a societal expectation that we're agreeable, that we conform, that we follow the rules, right? If you think of women versus men, girls versus boys, like we want to please more, I think, than boys maybe. And so we're going to adapt a little better. They say that girls also, the brains, girls' brains mature more quickly than, a female brain versus a male brain. So there's, more maturity. In ADHD, there's a lag in maturity in general, but probably, I don't know if there's a study that looked at this. If you look at girls' brains versus boys, if even having ADHD, the girls tend to mature still, don't lag as far behind as the boys in their level of maturity. So there's a lot more going on with just being female.
I had a couple other questions. One is something I think some of the other questions that I've heard people ask, and then some of the things I've heard you say have made me wonder about the idea of sort of ADHD being its own, ADHD being its own spectrum thing. So like how we see that manifest in terms of intensity, like maybe it's less a question of is that masked and more a question of like which symptoms appear strongly, which ones don't, and the variation in how much we see that as if on a spectrum. And also like how much do normal people who don't qualify for an ADHD diagnosis demonstrate things that are in keeping with ADHD, getting distracted, being forgetful, but it's not at a diagnosable level because, we all have some amount of it on a spectrum, but not the diagnosable end of the spectrum.
Yeah, that's a really good point. I've been trying to figure out like a good new name for this. And you're absolutely right. I think one of the words should be spectrum too. It's not black and white, as you saw and as we know. There are so many different symptoms. We just saw, 85 billion neurons and so many circuits that we have going on, and trillions of connections being made at any moment. Is all interconnected. It's complicated, and hardly anything is black and white. Things are on a spectrum, but will ADHD fall on the autistic spectrum or sensory autism spectrum, or have its own spectrum? That I'm not sure, but if anything, I would put it over as in maybe the high functioning autism spectrum, perhaps. But yes, to see it as, when I see patients, it can really, for example, I had a Eastern European engineer come to see me, and she has ADHD and wanted to explore medication. Very successful software engineer. And I said, well, why do you want to be medicated? You're doing all these other things, again, multimodal, like exercises, and exercising is very healthy and et cetera. And she said, well, because when I go to meetings with my team, I have difficulty word finding and remembering what was just said. So there's working memory there and verbal expression. And I said, well, is it because English is not your first language? And she's like, no, she speaks English very fluently. But that wasn't the reason. She's like, no, I'm just, these thoughts going through my mind all the time. And I can't articulate in a fluent, cogent way from, linearly where the other engineers can follow her. And that was distressing for her. So medication wasn't for her to be even, more efficient at work and productive, better performance because she was performing fine. It was more of that.
Huh.
And that's, medications can help with that as well. So now it's been several years now.
And then if I can just ask one more question, I work with a gentleman who, was suspected ADHD. He saw one provider. They said, you have anxiety and you're med seeking. And he saw a different provider and or went to one of the groups in the Seattle area that does the assessments and was like hit every box for ADHD, and is now working with another provider on what medication works for him. But he has a history of substance use and has a lot of, I'd say, like hesitation about what medications to use because of that history of substance use. And I'm just wondering how that shows up on your radar as well for people who are sober now and associate the idea of like taking a stimulant medication with like when they used to do cocaine all the time or that kind of thing.
Well, how about I tell you a story?
Sure.
Okay. Again, I was beginning to do this work, and I had this very handsome young man show up and say, he has a documented history of ADHD, and he'd like to continue medications. And I was, went over the history and everything and said, sure. A week later, I get a notice from where the transitional house, there's some noise, where he was living. And first of all, I didn't even know he lived in a transitional home called Oxford House, which is for usually adults who have substance use disorder issues and are now sober and clean. So the house wanted me to verify that he needed this medication, a stimulant. So I'm like, what the hell? So I call him back in my office and I go, listen, we're going to be really straight here. What the is going on? Like, I think there are a couple of things you forgot to tell me. And he's like, well, actually, yeah, I was an alcoholic, and I'm living in Oxford House. I've been there a couple of years. And basically, he was afraid, to give me this history. Because a lot of former substance users, are even afraid to mention it. In this case, he needed documentation for the house. I said, listen, I want to be really, I want this to be a very transparent relationship that I have with you, and I want you to tell me the truth, and I need to know, and I'm going to treat you. So as long as we're clear and we're open and honest, here, I'm going to work with you. He is now in medical school. He has a twin brother who's also in the house, also became my patient, also on medication, who's also applying to medical school.
Wow.
Now, these identical twins, very handsome men, by the way, they're cute. He's 36. So what is the likelihood of a 36-year-old getting accepted into med school? Very little. All right, and here are one of the brothers who's now attending, and they took the MCAT over and over and over, but they were committed to clean and sober living, and we're in this house here in Seattle, for years, and so I'm going to give them the benefit of the doubt. I am going to work with them. Now, there are choices in the medication, because I want them to succeed. They've already suffered, and they are showing me that they, we just can't throw the baby out with bathwater kind of thing. So I have to ascertain, is this for real? Is this person serious? What's the history here? Where are they living? Where they, I'm just not going to be blindsided about that, but that requires me to be, very attentive and to investigate and to have honest and open conversations. And then, work with them. Absolutely. And there are medications that I can prescribe that may be less There's less propensity for addiction. I'm not going to give those people, I would hesitate to give them like an instant release formulation versus a long acting, but there are choices. And I'm going to give them choices. I am certainly not going to turn my back. Because we saw here how prevalent ADHD is in that population. And if I don't treat him, and if I say no, what's the likelihood that he's going to relapse? You know, that's like shooting yourself in the foot. So I want to give him, you know, a chance. And I know these meds can be very helpful. So I do have an issue, as you can tell, with providers who just, you know, have closed that book because of past history. You know, so I do spend the time and to get a thorough history of substance use, et cetera, before, you know, and then talk to them and discuss with them what the options are.
Yeah, and you even seem to take it a step farther. Where you're saying it might be like almost the linchpin to their prolonged recovery.
Yeah.
Like it could be really vital to that.
Absolutely.
What about? So I've had clients who know they have ADHD and they hated the side effects, and I was gonna, one of my questions would be like, I know there's so many different kinds, and so I had some clients who are like, I just learned to manage it, like it doesn't cause me enough problems, like I figured out a system to overcome it, and I just don't like the side effects. And so I don't know if there's anything you can kind of offer us that kind of like, but because I'm with you, I only recommend people that like specialize in it, because I've heard of people going to PCPs and just getting thrown Adderall or nothing at all, or, you know, telling people they're ridiculous or whatever, they're, you know, seeking out stimulants, whatever it may be. So I always try to send them to someone that specializes in it. But can you kind of give me a general overview of like, someone's like, well, I don't like stimulants because stimulants do this to me. Like I don't have an appetite anymore, or I get shaky, you know, just kind of like what you end up doing when you realize people have sort of side effects that they don't want to deal with, and how do you kind of like ebb and flow that with them? Just so I kind of have an idea that I can like give them that motivational speech to go and try.
Yeah. To be honest with you, I don't know if it's because I've been doing this for a while, but I don't really get many complaints of side effects. And I have hundreds and hundreds and hundreds of patients. I think it really depends on the provider. I don't know if this is happening when you send them to a provider who does a lot of this, but I work around side effects. So by giving people choices, and I let my patients titrate the meds themselves. So I don't just say, here's the one dose, take it or leave it. We talk about all kinds of things. So I'll give you an example. I don't know if you've heard of Vyvanse, is a long-acting amphetamine, and the company came out with a tablet form, and this was about 10 years ago or so. And I started prescribing the tablet form to my patients, and the health insurance companies were all like, they can swallow, so they can do a capsule. And I'm like, no, I want them to have a tablet, because I let them titrate with the tablet. So I go, you know, you could start with a quarter of a tablet, or you could do a half of the tablet. I'm going to give you 60 milligrams, the highest tablet dose, and I'm going to instruct you and teach you on how to manage your own dosage. It's kind of like giving insulin to a diabetic. You know, there's long-acting and short-acting insulin, and they might eat cake today and maybe not much tomorrow. It's going to vary on, you know, how much effort it's going to require that day to do stuff, and then they can decide how much medication they might need to do it. So I want to keep these side effects minimal, and also give them the benefit of the medication. But I'm going to empower them. I'm like, these are the side effects. These are the benefits. Here are your options. I'm going to give you an instant release and a long acting. And your long acting release is going to be a tablet, just like your instant release. And you get to go and you can decide whether you want to take, how much long acting you want or short acting in any given day. So it's having that flexibility, and believe it or not, my patients really like that. Like, they feel empowered and they go, yeah, like today, I decided that I needed blah, blah, blah. And then, sometimes they'll say, well, should I just, sometimes it's appropriate where they are consistent. Like if they're overthinking it too much, because they might have a lot of anxiety and they're like, well, I don't know, and I'm like, you know what, just take this dose. I'll guide them a little bit more. But for the most part, empowering a patient to have those choices is really, I think, is the best approach. So it's also in their hands and they can decide. And I also talk a lot about nutrition, so to avoid those issues. So I go into what they could eat, like, when you take your med in the morning, it's a long acting, try to eat as much protein as possible, because protein will give you your brain energy throughout the day versus a bunch of carbohydrates, for example. So there's a lot of education to help avoid the potential side effects. Or don't take your short acting after 2 or 3 p.m. because if you do, you could run into worsening insomnia at night. So I think, that education, that awareness is very helpful to alleviate potential side effects and then discourage the patient.
Yeah, even with you just kind of saying like how you walk a patient through that, like I can ask them like when they've had, I haven't sent someone to a provider and had a negative experience. It's more they've been to providers in the past, and then they're coming with like, they just threw this at me, and even what you said before that you've heard happen, but you're even telling me like how you walk through someone and how I can say like, we want to find, if you want a provider that like empowers you to like have some leeway in how you medicate yourself based on what you need in that day, like let's find someone who will do that for you. Yeah.
Right. And also saying it doesn't have to be that way. There are many choices. There are different dosages. It comes in different formats, so you can gauge that. And I actually have a med log that I give patients when I start them on meds. So I came up with a medication log where they can log, all of the side effects and the benefits. Now, have I ever seen a completed one? No. Does it matter? No. They have it. It's there. Do I disown them if they don't come with their log the next time? No. Do I shame them and say, why didn't you freaking fill out the log? No.
I have one more question, or maybe 2 more questions. It's like something I thought about asking, but I feel like I already know the answer, which is like, if, especially for the adult ADHD, that research has really only just begun like 20 years ago. As a trans person, I am always curious about, how some of these things may or may not present in my shared community. And I also know the complication with that, which is that like a lot of the people from my shared community don't want to give information like that out, because then you're like identified as a trans person who has like a mental health issue, which could potentially mean that certain rights of yours get taken away someday. But if, like, I guess, do you know much about that? Or like, do you know of anywhere that would be a good place for me to look? Like, do you know of any trans providers who are really doing work around ADHD?
Well, what I can specifically no, but I have a number of trans patients. So I have a number actually of patients who, as adults, became transgender. And I don't see them any differently or treat them any differently. I don't know if the prevalence of ADHD is even higher in that population. I'm not sure if there are studies done, perhaps. What I find very curious is that my patients who transgender over are on hormones, right? So if you're going from male to female, well, then you're going to be taking estrogen. And I find that fascinating. Like, what are the effects on symptoms of ADHD if now suddenly you are taking a lot of estrogen and you're diminishing testosterone?
Yeah.
I find that fascinating. And I try to ask them specific questions about that because hormones affect neurons. We have receptors for hormones on our neurons. And so the fluctuation of hormones within the brain is very important. It's another factor in cognition and everything. And actually testosterone, they're lipophilic, which means they can cross the neuron's cell and get into the chromosomes, the DNA of a neuron, and change the genetics of the neuron. We know that. That's how hormones can affect us. So, for example, when girls and women, if I have my younger, even just a woman in general who has menses and menstruating, and her ADHD symptoms often worsen mid-cycle. Okay, or if you're perimenopausal, if you're neurotypical and are perimenopausal, you are going to act like an ADHD woman. So if you're ADHD and perimenopausal, that's like perimenopause squared. You are really going to be a basket case. So I am, my radar is up to really managing these women and saying, no, you're not crazy. You're actually ADHD cycling, and your estrogen levels are changing, going up and down. And then, the same thing in pregnancy, the same story. So you have to, I'm really fascinated by the transgender population. And now when you bring in exogenous hormones that they're not used to, how does that affect their ADHD symptoms? So I try to gauge that and work with them on that. Like, am I needing to give you more or less, or what? I work with them because I don't think we know.
Yeah.
And I want to know. I think it's important.
Wow. These are all, that's incredible. I want to be aware of time. Dr. Heithaus, you gave us a full 2 hours. Thank you so much. I know we could probably keep going and going. So sorry for those of you that still have questions. We can, bring those to the group for sure. And thank you.
You're welcome. Thank you for having me this Friday afternoon. You guys could be out enjoying the sun here in Seattle. But I really appreciate your time and your interest and what you are going to be able to give people, adults, being on the front line as you are. So I really commend you for being here this afternoon and for your interest so thank you.
Yeah, well, the respect is very mutual. The way you respect for and care for and empower your clients is incredible. So thank you.
Good. Thank you.
Everyone have a wonderful Friday. We'll see those of you at happy hour that are coming. Thank you so much.
Enjoy happy hour.
Okay.
You're welcome. Take care, guys. Bye.
Bye.